Dr. Vefdi, can you hear now?
Yeah, I can hear you.
Okay, good. We're starting in 1 to 2 minutes.
Okay.
Nigel, can you hear me?
Yep. Hi, Bene.
Okay.
Should we start?
Yes.
Okay. Can everyone hear me? Bene, can everybody hear me now?
Yes, the people who had the issue have fixed it, so I think everybody hears you now.
Okay, great. Well, welcome everybody. I'm Nigel Ipsley. I work with the USAID Assist project, and I'd like to welcome everybody to this webinar as part of the Quality, Equity, Dignity, Quality of Care Network. So today we're going to hear a presentation from Professor Vikram Datta from New Delhi, who will be talking about improving care within his own facility for newborns and then helping spread improvement approaches through a national network in India. Professor Datta is the Director Professor in the Department of Neonatology and the co-chair of the Quality Improvement Cell at his hospital, Kalawati Saran Children's Hospital. He's the author of multiple journal articles and the editor of multiple publications. We're also joined by Bene Walter, who is the host and the moderator for the presentation. She is, one of her roles will be to pass on the questions to Vikram. So anybody who has a question at any point during the presentation, please type it into the chat box. So the chat, you can see an icon for that in the top right-hand corner of your screen. And just make sure you're sending it to everybody so that Bene can see who it is, can see the question and pass it on to Vikram. So we'll have a presentation for about 30 minutes, and then we have lots of time for questions and comments after that. So Vikram, I'll hand it over to you. Thank you for agreeing to present.
Thank you so much, Nigel. Greetings from NQOCN in India to all participants of this webinar. I would take this opportunity to thank the World Health Organization and the Quality of Care Network for giving us an opportunity to share our work on quality improvement for newborn health from local solutions to national network.
Vikram, you're on mute. You're on mute. Unmute yourself.
Yeah, that's fine.
Okay.
So I would just like to start with basic demographics of India. So India, we all know, is a big country. It has a population of 13 billion. But the things which worry us most are the total maternal deaths, around 44,000 in 2015. Total neonatal mortality rate of India contributes to around 27% of the global neonatal mortality. And 20% of global maternal mortality is contributed by India. Well, these are some statistics which really bother us in India and also in the subcontinent. Now, if you look at the coverage of key interventions in India, there is a scope for improvement, as you will see from the data which I am just showing you. The antenatal care is only provided to children in less than 50% of the cases. Skilled attendance at delivery has now increased to 81%. Early initiation of breastfeeding is still less than 50%, and exclusive breastfeeding is close to 65%. Now, if you look at the postnatal visit of baby and the postnatal care for mother, it's well beyond 40%. And the national availability of emergency obstetric care is somewhere close to less than 40%. Well, there's a tremendous scope for improvement, and that is what brought us all together. And I'm sure we all look at this data very seriously and work to improve our statistics. Now, there are some resource constraints also which plague our country. The density of physicians per thousand population is around 0.72, less than 1 physician per thousand population. The density of doctor, nurses, and midwives in India is 24.4 per 10,000 population, which is very close to the global critical threshold identified by the World Health Organization, which is 23 per 10,000 population. Now, that does not mean that we have a pessimistic outlook. Now, there is something to be optimistic about, and this is that we have adequate preparedness to improve quality of care in India, and this has been identified by the World Health Organization. We have a vibrant leadership. We have identified our plans and strategies. We have identified our standards. We have our data reporting systems in place, and we have supporting systems to improve quality of care in our country. Well, these are some things on which we have to build and improve our indicators. So I'm coming from a hospital. Nigel has already introduced me. I'm coming from a hospital which is called Kalawati Saran Children's Hospital. It's part of a large 100-year-old medical college, the first medical college in India which caters exclusively to undergraduate girl children and girl students. And this is the Kalawati Saran Children's Hospital. It's one of the largest tertiary care hospitals in India, which is catering exclusively to the pediatric population. I work in the Department of Neonatology, which caters to a load of around 15,000 deliveries a year. We have 2,500 ICU admissions per year. We run a super specialty course of DM Neonatology, which is affiliated to one of the best universities, that's Delhi University in India. We are also a collaborative center and a national center for excellence for multiple national programs of Government of India and help the Government of India in policy planning, making guidelines, and also capacity building. And this has been going on for decades. Now, just a word about how our journey towards ensuring quality in SNCU started. Well, in 2013-14, I was part of a National Neonatology Forum of India. And that was the time when we started believing that we could accredit our SNCUs. And accrediting the SNCUs by a quality assurance mechanism, we thought was the best way, to ensure and deliver good quality to our people and our patients. Well, this led us further in 2014-15 to pick up and help states. And the states of Bihar and Meghalaya are two of the states which have the indicators which require a lot of improvement. And these were the states where in Bihar we ran a quality assurance program. And this quality assurance assessment for the roadmap for improvement of newborn health in Bihar was given to the government of Bihar for implementation. My group also assisted the state of Meghalaya and prepared a roadmap for improvement of neonatal healthcare facilities there. And this was basically a bottleneck analysis which used the WHO Global BNA tool. And when we, look at the Meghalaya data, you can see we assessed 5 facilities in Meghalaya. Now, Meghalaya is a hilly northeastern state of India. And we assessed these 5 facilities on 4 major bottleneck criteria. The first criteria was the health workforce. The second was the essential medical products and technologies. The third was health service delivery and community ownership. And you see that they were all pretty far away from the center point of excellence. But the thing which was most worrying is that the health service delivery was a major bottleneck. And this is where we thought we could set up our improvement goals. We also traveled extensively across the various maternal neonatal health facilities in India. We found that the neonates were coming in very sick conditions. There were, issues associated with asepsis, poor hand washing policies. There were difficulties in the infrastructure, postnatal wards, with tremendous scope for improvement. Well, this was something, which was universally present, and that made us think. We had a question staring at us, and this was the question that do we wait for the ideal conditions to come? Do we wait for the ideal resources? Do we wait for the ideal manpower to be in place? And do we wait for the ideal time to improve the quality of care which we deliver to our patients and our subjects who are reporting to our health facilities? Or the second thing is that we start empowering ourselves, we fix our problems ourselves, strengthen our systems, increase their efficiency, make them more equitable and transparent. But the problem here is without asking for any more resources. Because resources in low middle income countries, resources are hard to come by. So do we wait for everything to be there, or we can do something to fix our problem? Well, that is what led us to believe that there is something which we need to do to fix the problems of our country. And that is what started our journey in quality improvement. Well, in August 2015, that is nearly 2 years back, a team from Great Ormond Street Hospital, London visited Kalawati Saran Children's Hospital, and that was a team led by Dr. Peter Lackman. And Dr. Peter Lackman, the next couple of days, he organized a learning session on basic QI methodology, which was conducted in one of the large corporate hospitals of Delhi, that is Saran Bhartiya Hospital. And this learning session, we were invited. There were teams from All India Institute of Medical Sciences, as Lady Harding, a couple of us, which were invited to the learning session in basic QI methodology. And then that was it. This was the time when we were, initiated into quality improvement. Then for a year, nothing really changed. We continued to, be QA centric. We continued to practice evidence-based medicine. In May 2016, I was invited by WHO Regional Workshop for a WHO regional workshop for quality improvement for MNH in New Delhi. And it was during these 4 days that I really got a taste and a feel of the quality improvement process, and the point of care quality improvement manual was introduced to us. We were trained along with other participants from the Southeast Asian countries, and we realized that it is quality improvement which is the most important thing which can fix our problems in our subcontinent. Well, the very next month, we started QI coaching sessions at Kalawati Saran Children's Hospital, and then we were provided support and we were mentored by the USAID Assist team led by Dr. Nigel and his team, which were posted in Delhi at that point of time. Well, this was the very next month in July 2016, we started our first QI project on hypothermia at arrival, because that was one of the major problems which our unit was facing at that point of time. I will briefly take the participants to our journey, how we did this project, and how we then expanded it into a nationwide movement. Well, the first project which we did in July 2016 was reduction of neonatal hypothermia at admission, a quality improvement initiative. Well, you all know that hypothermia kills. Well, every degree fall in temperature results in a 28% increase in mortality. And the newborns who arrive in our NICU in Lady Harding Medical College had a complex problem. They were born, if you look at the left side of the slide, they were born at 7 different places. And from these 7 different places, they were transferred either to an intramural setup, that's the nursery, or if they were sick, they would come to my ward, that's the neonatal ward. But what was the main problem is that these birthing facilities were nearly half a mile away from the neonatal ICU. Because they were half a mile away from the neonatal ICU, not only did it take time for them to arrive at the facility, that is the neonatal ward, but it also exposed them to becoming hypothermic during transit, and that is what was really happening. Now we started our work in July, and you can see here from this run chart that the percentage of babies who were admitted to the NICU with normothermia was less than 20%. So we're getting close to 70 to 80% of babies who are coming with hypothermia. And then we started to work with sensitizing the staff to the problems which were there because of hypothermia. And this, led to an increase in twice the number of babies who were coming with normothermia. So we started getting twice the number of babies who had a normal temperature just by sensitizing the workers or the staff to the risk of hypothermia. Now we continued our improvement work well into September and October, and you can see the percentage of babies who came with normothermia started steadily increasing. We were all pretty excited with it. We had done some changes to achieve these results, and this was mainly maintaining the labor room temperature by installing thermometers in the labor room to encourage staff to increase the ambient temperature of the labor room, and also to have a log of labor room temperature, and also having a supply of pre-warm linen to receive the babies. This resulted in good results, and we were all enthusiastic. Our changes were working. We started analyzing our problems more and thought about making system changes. Well, I've told you before that our babies were born nearly half a mile away from the neonatal ICU. So they required a transport incubator to be taking them from the labor room to the neonatal ICU. But the problem which we noticed why the babies were arriving hypothermic despite the transport incubator was that when the transport incubator arrived at the neonatal ICU, it had already lost charge. So we identified why it had lost charge, and we told people to keep it charged before you transit it. And just to remind people, we stuck a notice on top of the transport incubator reminding people to keep it charged when it is not carrying the babies. Well, we had some initial improvements, but you see the sustainability was a challenge. That really did not work at that point of time. We thought that just by reminding people with a notice, it's going to work, but it really did not work. So we used some system changes to keep the battery charged. And the first and the most important system change which we identified why the transport incubator was not getting charged was that it did not have the charging leads attached to it. When we ran into 5 whys and tried to find the root cause, we found out that the charging leads were not available to move with the transport incubator because the nurse in charge felt that the charging leads would get lost during the transit, and hence she removed the charging leads prior to the transit and kept it in the almirah. So most of the time the transport incubator was physically present, but there were no charging leads available with the transport incubator to charge. So the first change which we did was that we taped the charging leads to the transport incubator by a non-tamperable, tape, and this led to the transport incubator moving with the charging leads. The second thing which we realized is, as we had 7 points from where the babies needed to be picked up, but we had only 2 transport incubators. So the transport incubator was moving from one point to another point to pick up the babies, and it was sometimes taking 10 to 15 minutes for the babies to be put into the transport incubator, and another 5 to 10 minutes for the babies to arrive at the NICU. So during this period, there were no charging bays which were identified at the points, at the 7 birthing points. So we set up dedicated charging bays for the transport incubators and labeled them that these are transport incubator charging bays. And when the transport incubator was waiting to scoop the baby, the transport incubator already had the leads which were taped to it, and they were put at that point, and this was well identified. This was one of the system changes which we did. So there was improvement, but as you know, our batteries were old. We were in a government setup. The batteries were not holding charge for more than 15 minutes. So we thought what to do. So the further changes which we identified and carried out, and these were the system changes, were that there were the transport incubator, the instructions were loud and clear on top of this, and this was system changes, that the transport incubator needs to be charged before transit and prior to return. So it needs to be plugged into the charging bay. It should be absolutely charged, and the moment it picks up the baby and comes to the neonatal ICU, waits for the baby to be offloaded, and then returns back, it is plugged again so that it doesn't lose any charge. And the second thing which we did was we started transporting the babies with pre-warmed linen. Well, this resulted in increasing the rate of babies who came to us with normothermia. And this improving temperature management during transportation is visible in this graph. And as you can see, the message which I want to give to most of my friends here is that July and August, these are very warm and humid months in India. But you see, in July and August, the mean monthly temperature was pretty high. But what you see here is that the percentage of babies who had normothermia is pretty low. So it doesn't translate that the mean monthly temperature which is outside will translate into a warm baby. And you can have hypothermic babies well coming to your setups even in the warm and humid climates. Well, this was something. So finally, when we looked at our data, and this project is still going on, what we looked at is that this is the blue line shows you the moderate hypothermia. What you see here is till April, and what you see here is that the moderate hypothermia has had a nearly 90% reduction. And when we also looked at the all-cause mortality per 1,000 patient days, we found that there was a 55% reduction in deaths per 1,000 patient days. Well, this was something which was remarkable. So not only had we improved our processes, but also we had got a significant reduction in the mortality, which was a significant outcome. And that's really, translated into more healthy babies going back home, and, a sense of satisfaction and achievement in the teams who were working on this project. Well, as I just shared my results, we had achieved a reduction in all-cause mortality, which was unprecedented. These were the initial results of Kalawati Saran Children's Hospital. And as I told you, Kalawati Saran Children's Hospital is a leader in neonatal care in India. And Kalawati Saran Children's Hospital initial results, we decided that this was the time that you need to have the results being disseminated to other teams. And these were the like-minded teams which were led by local champions. We organized multiple 2-day QA workshops based on the point of care quality improvement model. And we also organized the training of trainer sessions for these teams so that we have a pool of national trainers, because we understood that there's going to be a tremendous need for organizing these workshops all over the country. We capacity built our teams, we networked these teams, we provided them with on-site and off-site coaching support, and we provided them a common platform for experience sharing. Well, this may raise a question in your mind, how we identified the initial teams and what were the prerequisites for the initial teams. So the initial teams, how we identified the initial teams who would be ready to take up quality improvement work. Well, the most important point for us was that the teams which we felt would come and take up the quality improvement process needed to have a local champion for neonatal healthcare in place. And most of us, you know, neonatal fraternity in India is a pretty small fraternity. Most of us knew each other quite well. And we identified the local teams based on the presence of the local champion. Another thing which was very important in identifying the local teams in the initial part was that these needed to be geographically close to Kalawati Saran Children's Hospital and New Delhi. So it should not be very far. It could not have been something down south, because you know there were resources which were involved in traveling. And the third point which was very important was that the team should have voluntarily expressed their desire to be a part of the process. So initially we picked up the teams which were voluntarily expressing a desire to be a part of the process. And the last but not the least, the most important part was that the teams agreed to self-finance their travel and stay, because we did not have any budget, you know, earmarked to roll out such QI workshops for multiple teams at multiple places. So they had to self-finance their travel and stay in New Delhi. Now, there were some factors which encouraged the team to take up the QI trainings. Well, the teams took up the QI trainings at Kalawati Saran Children's Hospital and various other places in New Delhi because of the novelty. It was something new which they never heard about, some new method to fix their problems. They felt that they could have a sense of purpose into it. It gave them a sense of purpose. They desired to replicate the success stories of Kalawati Saran Children's Hospital and other facilities at their own setup. We widely propagated our success story and also told them that they could save lives, they could save money, they could deliver better quality of care by using the quality improvement process. And that is what created the desire in them to come and learn this skill. They also had an extreme desire to improve the clinical outcome of their patients, and that is what pulled them and encouraged them to take up the QI trainings. Well, these are photographs of some of the QI networking sessions which we held from October 2016 till date in August 2017. Well, there are lots of other sessions which I have not shown here. These photographs are only for representative purposes. You can see these are the teams and the number of individuals and the criteria I have mentioned, how these teams came to us before. Now, that brings me to another very important thing, and that is the finances for the workshop. Well, you know, nothing moves without finances. And the most important part, how we organize the workshop, the teams needed to travel and stay in the place where the workshops were done. So as I have mentioned before, the teams themselves paid for their travel and stay. They bore the financial burden of the travel and the stay at the local facility where the workshops were being done. Initially, to start with, USAID Assist project kick-started the whole thing. They paid for the venue, food and stationery for the first workshop in New Delhi, which was held in October 2016. Subsequently, the subsequent workshops, the venue, the food and the stationery were arranged by Kalawati Saran Children's Hospital in one of the workshops, and subsequently by IAP, local host, that is the Indian Academy of Pediatrics, and the Federation of Obstetrics and Gynecology Society of India, and multiple other venues in the country. Well, this is how we could arrange finances for the workshops. Now, I would just briefly tell you how we formed the National Quality of Care Network. By January 2017, as you've seen before, we had a national pool of teams. These national pool of teams, we also had national pool of trainers, which we had identified through the TOT training program. We had impressive results, and by this time we had a quality improvement cell which was notified by the director of Lady Hardinge Medical College, and I was the co-chairperson of this quality improvement cell. It was formed in Kalawati Saran Children's Hospital to further the cause of quality improvement in Lady Hardinge Medical College, and also to network and spread this message all across the nation. Well, with this pool, we together got, and it was a self-sustaining, I would say self-assembled network. And that was the time the National Quality of Care Network was formed. It formed as a fallout, as a result of, this systematic journey, and this was formed in August 2017. So the National Quality of Care Network, that is NQOCN, has certain objectives. The most important objective is capacity building. We believe in sharing the experiences and connecting the teams together so that they learn from each other. We also believe in one of the most neglected aspects in our public health scenario is community participation. We believe that the community should pay a greater attention, they should play a greater role in quality improvement, and that is community participation. And we also have the objective of partnering with like-minded organizations in taking this message forward. Our network right now extends across 9 states of India. We have nearly 70 to 80 teams which are networked right now, and the total delivery load is around 1,40,000 deliveries per year. We've got expression of interest from state NHM of Madhya Pradesh and also certain facilities in Punjab. Now who are the drivers? Who drive the NQOCN? Well, the NQOCN is driven by local champions. These are local champions at national level who have been advocating for the cause of newborn for decades. Like I told you, these were the people, the neonatal fraternity, who knew each other quite well, and most of them were in contact with each other, but they were not working on subjects which were related to QI. They had worked together on diverse subjects other than QI, and they had a common belief that they could not wait for the ideal situation, and they had to fix the problems themselves. And the problems were well identified, and these local champions found that the NQOCN provided them with a common platform for action, and these were the drivers which got together, formulated the NQOCN, and that is how the NQOCN was born. There were also cadres of healthcare workers who were previously uninvolved in decision making, and these were the cadres of the nursing, the nursing cadre and the subordinate staff cadre. They were never given a role, they were uninvolved in decision making, and these people were made a part of the NQOCN team. And when these people came to the NQOCN team, it not only increased their self-esteem and motivation to perform for the network, but also gave the network a wider perspective. We got the perspective from their point of view, and that is what helped us achieve our goals and sustain the network, and also sustain the motivation of our cadres to continue to work into the NQOCN. Well, just to summarize, NQOCN has no hierarchy. It's a flat organization. It is entirely voluntary. Anybody who wants to join NQOCN, be a part of the quality improvement process, is welcome. It's honorary. None of our trainers charge any money, any professional fees for delivering their services. They do it free of cost. It's not for profit. And like I told you, our financing model is self-financing. The teams pay for their travel and stay. The rest of the part is borne by the host institution. Now, what drives us? Now, NQOCN is driven by passion to improve outcomes. Most of the people, in fact, I would say all of the people who are associated with NQOCN are very passionate. They want to improve the outcomes. They want to improve the processes. The novelty of the quality improvement process is something which also drives us. Most of the people who are a part of NQOCN had never heard about anything like QI. They knew that there is something like quality improvement, but quality improvement so simple that you can do it in 4 steps and it is easily understandable, is something which drives them. The connectedness, most of the people, like I told you, knew each other well. They are connected and they are still connected. Willingness to change, accepting that there is a problem, being open about it, and having the willingness to change. Empathy, for your patients, empathy for their attendants, compassion for the patients, and the positive results which we are getting from the various facilities are the things which drive us. Now, I would just very quickly take you through our results. If you can see, we've got a mix of standalone private facilities. These are large corporate hospitals which are spread all across the country. These results again are for representative purposes. This webinar doesn't allow me to share all the results here, but what you can see here is some of our initial results which have shown remarkable results, from standalone private facilities, from standalone private facilities to standalone private nursing homes. And this is single, 2 doctor, 3 doctor facilities willing to change. Then you have facilities which are large, public sector hospitals, and these are results from Meghalaya, impressive results. We have got maternal child hospitals in northeastern areas. These are the results from the maternal and child hospitals. Simple processes being improved and significant results. And these are academic institutions in the northeast part of our country. You can see the results. Most of the results which we have achieved are phenomenal. And this is the major driving force for the teams to continue to explore QI and continue to delve deeper into the process, roll out new processes, projects, and involve more and more people. Now, we also provide coaching support. The photographs which you see here are the on-site coaching supports at various parts of the country. What you see here is a coaching support. We have a monthly QI meeting which we have started for the NQOCN, and we've had 2 monthly meetings, one in the month of August and another in the month of September. The October meeting is due on the 27th of October in New Delhi, and we have these meetings. Apart from the coaching on-site support, we also have online coaching. What you see here in this photograph is through the Zoom. We are connected through the internet, and this is a participant from Aurangabad, which is in Maharashtra, being coached by the facilitators who are sitting in Delhi. And then we have multiple WhatsApp groups, and this is a WhatsApp group snapshot of the labor room QI team of Lady Hardinge Medical College, and this is connected to me for coaching. And this is how we are, connected. We have 6 or 7 active QI groups in the country, and we are all networked together through WhatsApp video calls, and this is what we are using to cut on our coaching costs. Well, coaching can cost a lot of money, and coaching is the most difficult part to sustain. Well, how do we manage the finances for our coaching in NQOCN? Well, again, to start with, Assist initially paid for the coaching of travel and on-site mentoring and coaching in Meghalaya. Meghalaya NHM supported the coaching by travel and on-site coaching support through its internal PIP budget. Well, at this point of time, I would just like to tell you that the National Health Missions do not have any QI associated budget, and they use the budget from the trainings, and diverted it for implementation of the quality improvement trainings. Likewise, in Madhya Pradesh, 2 districts of Jabalpur and Katni also, allowed us to travel and do on-site mentoring of the SNCUs, and I piggybacked the QI trainings on the on-site mentoring of the SNCUs in Jabalpur and Katni, and that is where we started the coaching for the QI in these facilities. The individual facilities bear the cost for the monthly QI meetings, like I just showed you in the photograph. They take care of the local hospitality, and it is from the individual facilities. The National Quality of Care Network provides free off-site mentoring and on-site mentoring if it is paid by the host. So this is how we are arranging finances for our coaching support. Now that brings me to the concluding parts. What now? Well, the 2 major things which we think right now are most important for NQOCN are, the first is expansion, an expansion to more peripheral facilities, because that is where quality improvement is needed the most in India. We have nearly 20,000 birthing facilities in India. That is where quality improvement is required. So we have the tremendous challenge of expanding geographically, We have our pool of local champions, trainers, coaches, teams and facilities. We have to expand that, because you know India is a vast country, and if we have to reach more peripherally, we have to expand our pools, and we also need more partners. We are looking out for partners, and recently we partnered with Neonatal Transfer Services London, who have very actively partnered with us, and we are very thankful to them. And we are on lookout of partners, and we are actively partnering with USAID Assist. Initially they've been our partners, they've handled us, and we are tremendously indebted to the support which has been provided by USAID Assist and World Health Organization in mentoring us and providing us with the initial training, and this is what it has led to the formation of NQOCN. The second most important part is sustaining. The sustaining part in the QI programs, you know, that's the most important part. And in sustaining, the most important thing which we feel which sustains the network is keeping the interest alive. If your teams are interested in what they are doing, if the teams are interested in the outcomes and the teams are enthusiastic, they would sustain into the network, they would sustain into the ongoing quality improvement initiatives. The second most important part is that nothing can sustain without a robust financial plan. We are on a path of creating a good financial plan for sustaining NQOCN, and we are talking to financial planners, and very soon we would have a robust financial plan for sustaining the network. We are also planning to move towards a formal organizational structure. Well, that is something which we are debating at this point of time, whether the formal organizational structure is going to help the organization. Well, the majority of the people, the local champions who are in the organization, feel that a formal organizational structure would help the organization in the long run. Now, finally, to conclude my session, there are certain learning lessons for any one of you who wants to replicate or who wants to build up on our experience and create something similar in your countries. Well, it's very important that we have formal networks of quality of care, but at the same time, the informal quality of care networks can play a very important role, and I would say this role is complementing the formal networks of quality of care. So you can form an informal quality of care network, and this informal quality of care network can complement the formal quality of care network in your country. The second fact which you need to realize is that the majority of the healthcare workers want to improve outcomes but lack the skill and the system support to do so. So you have to realize this fact. You have to skill them, you have to prepare their systems, you have to strengthen their systems to provide them the proper support and the milieu and the environment to practice and deliver quality of care. You have to attach value to work and expose the teams to a practical method to improve clinical processes. And this, is going to help the teams to work cohesively, and that is what you want. The last part is that you have to identify and reconnect with local champions. And these local champions require a lot of nurturing. These are the local champions who may be hidden. They may not be in front of you. You have to seek them actively. You have to provide them the environment to learn, and you have to empower them to spread this learning. That is something which is most important. And this is for the administrators. You have to go beyond your preferences. You have to go beyond your comfort zones. You have to go beyond the branding to pick up your team. Don't think that only the large institutions can work. Don't think that only particular individuals can work in QI. You have to seek local champions, identify and empower them. And the last thing which I would like to tell to all my friends sitting in various countries, do not wait for an executive order to act like us. Start your improvement work now, because now is the time. If you start now, you can save many more lives. Don't wait. And lastly, the key mantra to sustain any network, we feel the most important part is plan a good, robust financial plan. You should have finances. Without finances, it's very difficult to sustain. And perseverance is the second greatest quality, I should say. Anybody who is part of a nationwide network which has assembled and which is trying to self-sustain, the perseverance, the patience is the most important part, and connectedness and communication is something which is most important. Well, with that, I would like to acknowledge my friends and my partners, USAID Assist Project, Lady Hardinge Medical College, my parent institution, World Health Organization, Dr. Nigel Lewisley, Director South Asia, USAID Assist, Dr. Mehtab Singh, Senior Improvement Advisor, Dr. Sonali Vyad, Senior Improvement Advisor, URC, Dr. Ankur Sodan, Dr. Parika Bawa, URC, Dr. Abhishek Bhartiya, CEO of Sitaram Bhartiya Hospital, New Delhi, Dr. Rajesh Mehta, WHO CRO Office, New Delhi, my resident doctors Shrishti and Sanjana, my nurses Jeena, Bhavna, and other staff of Neonatal Ward and Nursery, Lady Hardinge Medical College, and my mentor, Professor Arvind Sari, former head of neonatology at Lady Hardinge Medical College. Thank you.
Thank you so much, Vikram. Nigel, are you here? Nigel?
Thank you, Benedict.
Okay, I think we may have lost Nigel. In any case, thank you so much, Vikram, for this very inspiring presentation on results and also how to get started and how it relies so much on motivation, passion, and connectedness. You have had a few questions coming in as you were talking, so I'm going to read this one out. People on the call, there's many of you, there's 73 of you at the moment. If you have more questions, please type them in the chat. And what's going to happen is Vikram is going to answer as many as possible in the remaining 15 minutes. And the question we cannot answer today, he will answer online. So we will post all of your questions that you're writing today on our website, and then he will answer them online, and we'll send you the link to all this. So don't refrain from asking your question if you think we're running out of time. Vikram, the first question was from Bakodi Ramihov. Yeah, he actually has two questions. First, he asked whether Lady Hardinge Medical College is a government hospital or a private one, and then he asked how you motivated the staff to improve quality of care.
Okay, so thank you so much for your questions. Lady Hardinge Medical College is the apex medical college in India. It's part of the Government of India. It's governed by Government of India, and it's a government facility. So that, I hope, answers the first question. The second part is motivating the staff. Like I just showed you my journey into quality improvement. The most important part which motivated the staff were the results, The results, when we saw the results and when we started having a decline in the mortality of the ward, that is what, certainly motivated the staff to work more. And the second thing which motivated them was the novelty and the simplicity of the whole point of care quality improvement process. So I think these were the two things which motivated, and also empowering all levels of staff, that is our nurses as well as the subordinate staff. For the first time we had the IRs, the subordinate staff sitting in my, quality improvement meeting. And the first time I called them, they were pretty surprised that they were being called for the first time in maybe 20 years to be sitting with the directors and giving their suggestions how they could improve the quality of care. Well, this is something which motivated all of them, and that's how we function.
Okay. Thank you. We have two questions from Mike English. The first one about how you manage to mobilize internal resources in terms of time and effort from the existing staff in the facility and elsewhere. How do you do that?
Okay. Now, if I talk about the time, the most important part is that the time was decided at a mutually convenient date, because most of the nurses are on very tight shift duties. Most of the IRs are on shift duties. So most of the meetings which were held during the time of changeover. So the staff which was coming for changeover, suppose the changeover time was 2 p.m. So the staff which was coming in came at 1:30 p.m. and the staff which was about to leave at 2 p.m. had most of the work which was in place. They had done most of the work, so they would attend at that point of time. And we would get people from 2 shifts who were coming. So I just gave you an example how we motivate, how we could manage the time. The second most important part was that also, the resources, online connectivity was one thing which really helped us. We had the WhatsApp groups which were running up, and like I've heard other friends also on the QOC network, the WhatsApp video calls and the WhatsApp groups and the telephonic conversations, they really saved the time. We've also published an article, Parika has done an article on URC USAID Assist website, where we've shown that it saved 65% of the cost and also reduced, more than 24 hours of the mentor's time by doing online mentoring and coaching. So this is how we did the resources. Regarding the money part, I have shown in my previous slides the money part, how we financed most of these, and I come back to the slide again. And these were individual facilities, the national health missions. Initially to kickstart, we had the assess, and then NQOCN is providing it. If anybody pays, then on-site mentoring would be done. Otherwise, free off-site mentoring is available, and we are really connected. And most of the teams know us. We've already done a preliminary QI workshop. That's the way we are arranging the finances.
Mm-hmm. Thank you. The second part from Michael's question is how important you feel it was to travel between your center and the one where the QI work was happening. You also asked how you paid for that, but you answered that later in the presentation, so I think that's clear.
Yeah. So, it was not only us traveling. We have local champions at all places. Like in Northeast India, we have the people who've been identified there. So we have empowered the local champions at this point. And the table facilitators, the people who facilitated during the QI meetings, the teams, they are directly linked, and they are the people who are continuing well beyond the QI workshop, the 2-day QI workshop. Like I facilitated Government Medical College Aurangabad, which is in Maharashtra. So I'm still in touch with Government Medical College Aurangabad, and that's through the WhatsApp. We also have the local facilitator who, organized the workshop there, who's the local champion. So in case there is any requirement for us, to have an on-site visit, because we want to cut on finances, we have the local facilitator. That's, for example, in Aurangabad, we have Dr. Kedar. So Dr. Kedar, travels to Government Medical College. And in case there's some issue which he cannot, settle at that point of time, or a wider discussion is needed, we connect through video calls. So that's how we are doing it.
Okay, you have a question from Anand Kumar on how you calculated patient days.
Okay, how we calculated patient days is, suppose for the mortality, we want to calculate the mortality. So we had a particular, suppose we had 30 days. In a particular month, September, we had 30 days. So the first is the total mortality which happened in, the numerator would be the total mortality we had in September, and the denominator would be the total census of September. The total census of September would be the total number of patients which have been present in the ward or that facility for entire 30 days. That, for example, on first we had 54 patients, second we had 62. You add up all the patients in the entire 30 days, that gives you the denominator, and you multiply it by 1000. That is how we are getting patient days per 1000. That's the mortality per 1000 patient days. That's how we did it.
Okay, you have a question from Atna Fugetachu on the example you gave on hypothermia reduction, and he asked whether you have done an analysis to show how much of the neonatal mortality reduction was due to the reduction in hypothermia.
Yeah, we actually, the most of the other processes were going as it is. The hospital did not have, the only change which we started when we had the hypothermia process which was started till January 2017, we just had the hypothermia project which was running. On January 23rd, we started another project which was the late onset sepsis reduction process, and this was through intensified hand washing using the glow germ solution. So this was the overlap quality improvement process which started from January onwards. So these were the two quality improvement processes. Rest, all other management which was being done in my neonatal unit was protocolized. So there was no change. So these were two changes: getting more babies to come to us by staying warm, and also washing hands appropriately for all level of staff which were handling the babies. Now combined, these two led to a reduction in the mortality. So exactly causality association with hypothermia at this point of time in April has not been established, but these were the 2 QI processes. Just to make it simple for the attendees, I have not shown the late onset sepsis reduction data, but if somebody wants, I can post it online and that can be done. So we have 4 lines in that graph really.
Another question from Anand Kumar on still on your example of hypothermia. How are you planning to extend it in Bihar, and up to what level, tertiary, or primary healthcare centers?
Yeah, in Bihar, the most important point is we just visited Bihar a fortnight back with Government of India team, and we have sensitized the Government of India team there also about the importance of quality improvement. We shared our results with Government of India officials, and they've been well aware, and they are part of major teams will go out in Bihar. We're looking forward to spreading it in Bihar, but the most important point is we need a partner, and we need the National Health Mission of Bihar to collaborate with NQOCN or ask us to come over and roll out the quality improvement work there. Because we've just done the roadmap for Bihar, and this was around 3 years back, and Bihar now needs the quality improvement to take this forward.
Now, Dr. Zudi Mulisa from Ethiopia, on your suggestion or your recommendation even to not wait for an executive order to start working on QI. You mentioned that financial and other support is required for this kind of work. Is it not good to work with leadership from the very beginning, in your view?
Yeah, in my view, it is essential to have the leadership on board, and that is what we had. When I talked about the quality improvement cell, if you go back to my slide where we showed you how we formed the NQOCN, you will see that it was predated by the formation of the quality improvement cell at Kalawati Saran Children's Hospital. And that is where the leadership came from. We had the head of the Department of Pediatrics, we had myself as co-chairperson into it, we had the entire hospital, the director was on board, we had the Deputy Commissioner Child Health, Government of India on board, and we also have key government officials who've been informed about it. And the entire leadership, definitely it is a very big plus, because without the leadership being on board, you cannot move. And it would be great if you can have the leadership on board. So don't think that we were starting without the leadership on board. We already have all the leaders who are well acquainted with this and who are well aware of this.
Vikram, we have more questions coming, so we're going to take 3 more, and there will be 4 or 5 left that we're also going to post online with all the other questions.
That should be fine.
One of them is whether QI, that's a question from Javad Suri, whether QI can be part of an accreditation process of a hospital. And if so, do you have any models that you can share with this group?
Well, if you talk about the accreditation and QI, they are 2 different things. Well, in accreditation, the QI is the next part of the journey towards the quality improvement, is the next part of the journey. Initially, in India, we are following the QA, and we still are following in some parts of the country. That's the quality assessment assurance part. And quality improvement can be inbuilt. But the most important part is that certifying the unit as having quality improvement practices in place, you need to have a body which will evaluate, a body which is going to monitor, and the body has to, handhold the unit, and the unit has to continue to, show their results, share the data, and continue to practice quality improvement. It is not just one time that you did a project and the project gave you some results and then you are certified for 3 years that you are practicing QI. Your results may very quickly, as all of us who are doing any QI project, the results may very quickly come back and you may start having a flip-flop of your data, which would be just a random, without any intervention. So it's important that it's a sustained effort and you need to have monitoring for that. Right now there's no model, but it's a good suggestion.
On expansion, there is a question specific to India here from Sanjeev Kumar. How did you mobilize the government of Madhya Pradesh and Meghalaya to pull out the resources while the government is still completely focusing on quality assurance work?
Yeah, that's a very good question. I would take Meghalaya first. Well, Meghalaya first approached me in 2015, early 2015. They told me that they wanted to accredit their units, the 5 SNCUs, and I should help them with, running a background analysis, whether they were fit for accreditation. And, somehow through our advocacy, we assembled a team of national experts, and we motivated them that we need to, assess the facilities using the WHO-BNA tool. And that was the time when we started visiting these facilities, and we used the tool, and I shared one of the final graphs also in my presentation earlier today. And this was the time that we identified, some places where improvements were needed. And there were short-term, medium-term, and long-term, suggestions which were given in this document which we submitted to Meghalaya. And at that point of time, we realized that just giving them the document and, it would just go into the almirah, it's not going to work. And that was the time, when we were, part of the ongoing QI process. It had started in Kalawati Saran 2016. We were, working very closely with the assist team. And that was the time we realized that to fix the problems in Meghalaya, we need to have, the quality improvement coming in. Because that is the most, easiest way and the most efficient way to fix it. So that was the time they were introduced in Meghalaya to quality improvement, and they put out some budget from the trainings, like I told you, because the PIP of Meghalaya doesn't have any budget for quality improvement work. They pulled out the budget from quality assurance teams, and they diverted it towards organization of the quality improvement workshop in Meghalaya, and most of the on-site support was done.
Okay, Vikram, we have more questions specifically on data and one on information sharing and knowledge sharing, but we're running out of time. So I will share those with you straight after this call, and we can post them online with your answers. I would like to thank everybody on the call for such an incredible group that let the presentation happen and had these very insightful questions. Thank you very much. We're going to send you the recording of this session together with Vikram's data presentation and the Q&A as a link to all that, so you can continue the discussion if you wish to. And I will also include in this message the website of the National Quality of Care Network in India that Vikram just detailed to you. Please mute yourself. We're just closing down. Vikram, thank you very much for that. Nigel, thank you also. We lost you on the way.
Thank you.
Thank you for your time, and please continue the conversation online. I'll send you the link in the coming days.
Thank you.
Bye.
Great, thanks. Thanks, Bennett. Thanks, Vikram. That was a great presentation.
Thank you, Nigel. Thank you, Benny. Thank you so much.
Bye-bye. Thanks.
Thanks.
like